So today I'm going to discuss on the presentation that you guys have been dealing with the whole day. So the first case that you're going to highlight is the one that is dealing with 1, 2, 3, 4. So in this presentation, we are going to discuss about the role of ultrasound in pre-eclampsia management. So these are the table of contents. Introduction, IUGR, the brain sparing effect, umbilical artery Dopplers, medial cerebral artery Dopplers, ductus venosus Dopplers, and the placental morphology. This is the introduction. Pre-eclampsia, defined as de novo hypertension above 140/90 millimeters of mercury, appearing after 20 weeks of gestation, accompanied by proteinuria, which is greater than 0.3 grams per 24 hours. It remains a major source of perinatal growth restriction, prematurity, and death worldwide. Since its introduction, practitioners have increasingly utilized fetal ultrasonography for the management of preeclampsia. Ultrasonographic diagnosis modalities, including fetal biometric growth curves, the biophysical profile, and umbilical artery Doppler, have been used to detect fetal growth restriction and assess fetal well-being, respectively. So, Doppler studies of the middle cerebral artery, the uterine arteries, the ductus venosus, and placental morphology offer additional utility in the prediction of adverse pregnancy outcomes and as a potential screening test for preeclampsia. The burden of fetal growth restricted fetuses FGR, SGA is higher in resource poor countries, and children born of FGR, SGA have a higher risk for mortality and morbidity during the neonatal period and beyond. So, pre-eclampsia screening recap. So the uterine artery Doppler studies, both in the second and the first trimester, can predict pregnancies at increased risk of the complications of impaired placentation. The sensitivity for predicting severe preeclampsia ranges between 80 and 90 for a false positive rate of 5 to 7%. So we use the umbilical artery to determine preeclampsia in the first trimester. So you can see this is a normal waveform. So when there's notching here, meaning they say that there's a higher resistance in the flow of blood in the uterine artery, that is an indicator of preeclampsia. So let's talk about the intrauterine growth restriction, which is IUGR. What is intrauterine growth restriction, IUGR? Intrauterine growth restriction, or IUGR, describes a decrease in fetal growth rate that prevents an infant from obtaining his or her complete growth potential. Small for gestational age, SGA, is defined as a birth weight of less than 10 percentile for gestational age. So what are the factors that can lead to IUGR? Maternal factors, we've got age, small stature, high altitude, genotype, stress, preeclampsia, substance abuse and use and abuse, undernutrition, overnutrition, hypertension, prior IUGR. Then also we've got the infections, touch infections, malaria, touch infections and malaria. So fetal factors, congenital heart disease, congenital diaphragmatic hernia, trisomy 21 Down syndrome, trisomy 18 Edwards syndrome, trisomy 13 Fetal syndrome, then the Turner syndrome. We also have got the placental and cord abnormalities, placental insufficiency, reduced amino acid transport, reduced oxygen delivery, reduced neuroreactive substance production, incorrect cord insertion, placental tumor, single umbilical artery, circumvallator placenta. So intrauterine growth retardation in preeclampsia. Preeclampsia is also associated with a fourfold increase in the risk of IUGR, which is linked to both short-term and long-term health consequences. Those affected by IUGR are at risk of obesity, cardiovascular disease, hypertension, and diabetes later in life. So, what is the brain sparing effect? Brain sparing is an adoptive phenomenon, redistribution of blood flow to the brain, observed in fetuses exposed to chronic hypoxia who are at risk of intrauterine growth restriction. By redistributing blood flow, the fetus attempts to maintain the oxygen and nutrition supply to vital organs, especially the brain, heart, and adrenal glands. Since the major beneficiary of redistribution is the brain, these flow alterations have been designed as achieving brain sparing. So these are the normal growth charts in a fetus. So you can see this is for the BPD, biparietal diameter. So you can see the blue marker there. It shows that it is within the upper and lower center. So anything that is within this shows that it's normal growth of the fetus. The same for the head circumference. You can see that our pointer is here, which is within limits. And you can also see the estimated fetal weight is here, which is within limits. Then if you look at the abdominal circumference, you can also see the blue pointer there is within limits. The femur length is also within normal limits. And you can see here also the RI is within limits. So the umbilical artery Dopplers, so you can see this is how we measure the umbilical artery. So this one is a normal waveform there, the normal waveform. And then for the medial cerebral artery, this is a normal waveform with higher resistance. Sorry, here for the umbilical artery, here you can see that there is a bit of a notch there. Sorry. This is the uterine artery Doppler, not the MCA. Sorry for that. Then you can see here in the middle umbilical artery again. You can see that there's a notch there, there's a notch there, there's a notch. So when there's a notch like that and there's absent end diastolic flow there, it means there is higher resistance. If you look here, you can see that there's a reversal of flow of blood like that. That's the reversal there, meaning to say that the baby is at risk and die anytime because the flow of blood in the umbilical artery is reversed there. So here now, this is the middle cerebral artery flow. So you can see this is the Seco Willis there, and you can see this is the middle cerebral artery and this one, these two, right and the left side. So this is the MCA Dopplers. So a normal MCA should have a higher resistance flow. So you can see this one is a bit of a higher resistance compared to this one. This is low resistance. You can see that this is a low resistance flow, and there's a reversal of flow in the middle cerebral artery. So when there is a higher resistance to flow there, it means a lot of blood is going into the brain, which is suggestive of uh, suggestive of what the brain sparing effect. So this is now showing that there is a placental insufficiency and the fetal redistribution of blood is taking place. So this is the ductus venosus. So you can see here we do have the ductus venosus here that is coming here. This is the umbilical vein there. This is the IVC. So it's connecting the umbilical vein to the IVC. This is our ductus venosus. So you can see here, you see it using the on color Doppler. It has got aliasing there. So you can see the mixture of colors there, the red, the yellow, and a bit of blue there. This is aliasing. So the ductus venosus is a small vein. That's why you see it has got aliasing there. So the ductus venosa waveform, so you can see this is the normal ductus venosus waveform there. You can see that the A wave is absent there and there is no reversal of flow. So the abnormal ductus venosus, this is a positive A wave is here. So here is an abnormal ductus venosus, the reversed A wave. You can see that the A wave is reversed there. So this is abnormal, but this is a positive A wave, there, which is normal. So abnormal cerebral placental ratio CPR. An abnormal CPR reflects redistribution of cardiac output to the cerebral circulation and has been associated with the intrapartum fetal distress, increased rates of emergency, cesarean and NICU admissions, and poor neurological outcomes. So the CPR is the mean MCA positive index PI over the mean umbilical artery PI, MCA PI over umbilical artery PI in one umbilical artery. So the cerebral placental ratio there versus the weeks in age. So this is the 50% of the lower centile. This is the 950 centile. So anything that is between the 950 centile and the 50 centile here is normal. Anything that is above or below is an outlier, is abnormal. Abnormal placenta morphology in pre-eclampsia. So we have got placental infarcts. So you can see here there are some placental infarcts that we have there. Then we also with placental hemorrhage. So you can see there's a hemorrhage, there's a clot there, retroplacental hemorrhage there. If there's a hemorrhage there, it can also be an indicator of placental abruption. Massive perivillous fibrinoid degeneration, maternal flow infarct, MFI. So massive perivillous fibrinoid degeneration, maternal flow infarct, MFI is a relatively rare condition characterized by severe early fetal growth restriction, FGR, or intrauterine fetal demise, IUFD, with features of uteroplacental insufficiency. So you can see how it appears like. Then you can see that there's some degeneration that is happening there. We can see there's some cystic degeneration, there's some fluid degeneration. So this is what is called the massive perivillous fibrinoid degeneration of the placenta. Other placental changes in pre-eclampsia: thin, dense placenta that is less than 2 centimeters in thickness, appears homogeneously dense and echogenic due to severe limited blood flow to the placenta and extensive infarcts. So motor the placenta, unique appearance seen only in PET, with areas of subtle increased echogenicity give placenta a motor appearance. Code France. Echo-dense areas can change into echo-free spaces, infarcts over days. So we got a thin placenta there, that's a thin placenta. With the motor placenta, you can see there's some calcifications which are within the placenta. So surveillance early onset of FGR. FGR, normal Doppler growth scan every 2 weeks. FGR, abnormal Doppler, we recommend a high with a high umbilical artery PI above 950 percentile and low MCA PI less than 50 percentile. Then we recommend weekly Doppler scans. Fetal growth restriction, abnormal Dopplers, absent or reversed, and diastolic flow, umbilical Dopplers scan every 3 days. So those are the recommendations when it comes to surveillance of fetal growth restriction. When then is the decision to deliver recommended? Below 32 weeks. Doppler criteria: absent or reversed ductus venosus airwave, high ductus venosus PI. Delivery should be done urgently. Surveillance for late onset of fetal growth restriction. Fetal growth restriction, normal Dopplers, 2 weeks growth in Doppler scans are recommended. If elevated umbilical artery Doppler PI, weekly Dopplers with the biophysical profile score is recommended. Low MCA PI or CPR, 2 to 3 times per week Doppler with the biophysical profile score. So when is the decision to deliver? After 32 weeks recommended. Abnormal Doppler criteria, umbilical artery PI above 95%, MCA PI less than 5% in 37 weeks, then deliver. R over A in diastolic flow above 32 weeks, deliver. So EFGR, normal Doppler criteria, deliver between 38 and 39 weeks. So IUGR case study from Iraq, so you can see that here we have got the umbilical artery, and you can see that there is absent any diastolic flow, as you can see here. So these are the case study abnormal biometrics. So these are just abnormal biometrics that we are having there. You can see the BPD here is 35 weeks, 1 day. The head circumference is here is 31 weeks, 1 day. Then the abdominal circumference 23 weeks and 4 days, which is less than the normal centile. All the readings, you can see that this is less than the second centile, this is less than the second centile, this is also less than the second centile. So abnormal growth curves of the same case study. So you can see here the BPD is just on the borderline, and then the head circumference just on the borderline as well. Then you can see that the estimated fetal is below the lower centile there, and the abnormal circumference below the lower centile, and then also with the female length that is below the lower centile there. So they are also what we call the constitutionally small fetus for the gestational age. So don't mistake constitutionally small fetus for gestational age. This can be small due to the genetics. So you can see here with the case where we suspect the fetal growth retardation. This was what was suspected on the request form, and then you can see here the BPD was 33 weeks 0 days, which was less than the second centile, but you can see the head circumference was within normal limits, and the abdominal circumference was also within normal limits. So you can see that the female length was also within the limits, and you can see for this constitutionally small fetus, the umbilical artery Dopplers was very normal. Constitutionally small fetus for the gestational age, so you can see here the BPD is within limits on the borderline there, and the head circumference also borderline. Then you can see the abdominal circumference is borderline. Then the female length is also borderline. The estimated fetal weight is within normal limits, and the umbilical artery Doppler is within normal limits there. So pre-eclampsia screening management guidelines. So all Wales maternity and neonatal neonatal guidelines, small for gestational age in fetal growth restricted babies, antenatal management. This one is you can read on this. They have got guidelines for pre-eclampsia management guidelines. So they adopted these new guidelines, which were adopted in August 2024. I haven't seen the new guidelines or the updated guidelines, so you can read on this. All Wales maternal and neonatal network guidelines. So you can have a look at that and see how they have recommended that pre-eclampsia management should be done. So there is just an organogram on how you can manage high-risk pregnancies. Again, so in conclusion, the following Dopplers should be done as part of risk assessment: preeclampsia, umbilical artery, MCA, middle cerebral artery, ductus venosus, and the uterine arteries. Early diagnosis, close follow-up, and timely delivery of pregnancy with fetal growth restriction are of crucial importance for perinatal short and long-term outcomes. Thank you so much for your time. I hope it was educative. Don't forget to subscribe to our channel and also share our free educational courses. Thank you so much.